followers of Neuro Takeaway, welcome back to the channel. Today we're going to talk about the imaging of the aggressive forms of demyelinating diseases. As you know, every disease can have different level of aggressiveness, and demyelinating disorders do not skip this rule. It can be mild, moderate, or severe. Here you have a classification of the most important and frequent demyelinating processes based on immunology. Here we have MS. As you know, 80% of these patients have oligoclonal bands in the CSF. We have NMOSD, neuromyelitis optica spectrum disorders, in which around 80% of the cases have AQP4 antibodies. There are another 10 or 15% with anti-MOG antibodies, and the rest are double negative. Maybe there are still some antibodies to be discovered. And finally, we have ADEM, acute disseminated encephalomyelitis, in which, at least in children, there are around 50% of patients with anti-MOG positive antibodies. Okay, but what is aggressive? What do we mean by aggressive? It's a complex concept that has to do with many things. Here we have a classification, a score that is very useful in MS patients, based especially on motor abilities, that goes from 0 to 10. It is the well-known EDSS scale. But the importance is not just the graduation of this score, but the speed in which a patient reaches a certain level. And there are other factors that are very important in a patient that are not measured by this score. Here we have a list that was stated by Mark Freedom, in which he talked about the level of fatigue, the ability to perform certain daily life activities, the ability to work, to find a job, or the cognitive or psychiatric dysfunctions. And regarding imaging, we have to think that imaging is not directly related with aggressiveness. I mean, the pattern may be misleading, and it all depends on the type of disorder. For example, here we have an 18-year-old teenager with a first episode of ADEM. You can see the ugly aspect of these images with a lot of hyperintensities in both brain hemispheres. They are almost symmetrical. They involved the basal ganglion, but after treatment, an empirical treatment with steroids, this patient almost completely resolved the lesions. Another case that is very telling regarding the misleading or the potential misleading images pattern regarding the evolution. Here we have a patient that I had the opportunity to see many years ago with a right hemiparesis. He was about to be undertaken biopsy by the neurosurgeon, and as you can see, he had a very typical pattern of a tumefactive lesion with an open ring pattern of enhancement, a peripheral restriction, and this typical pseudotumoral spectroscopic pattern with high choline and lactate. This patient evolved very well after steroids. You can see at 12 days, at 30 days, and at 60 days, a very good evolution with shrinkage of the lesion, and he did well until now. So these tumefactive lesions can be associated and are frequently associated with very good evolution. It is considered that around 30% of these cases do not have any relapse in the follow-up. Well, let's talk now about multiple sclerosis, which is the paradigm of this group of lesions. Living to a natural evolution, this process is quite aggressive because it has like two phases. The first phase is very inflammatory. You can see here the arrows represent the MRI activity, and there is a lot of activity at the beginning of the process. But after some years, 10 years, 15 years, the process becomes less active on images, but there is evolution, a steady evolution regarding the loss of brain volume, which is very worrisome because it's associated with cognitive decline. These processes are believed to coexist from the beginning, but the neurodegenerative phase is more associated with the chronic progressive pattern of the process. And in 2005, Bielokova published this very interesting paper showing that the pattern on imaging may be dissociated regarding the presence of inflammatory or neurodegenerative characteristics. For example, you have here low inflammation on FLAIR, but one has normal brain on T1, the other a little bit of atrophy. Here, high inflammation without atrophy and high inflammation with atrophy. So you can have all the combinations, and these two characteristics are not always dependent one on another. Well, in 2018, a group of experts from Europe gathered together in trying to reach an agreement about the concept of aggressive MS, but they didn't reach that agreement. Even though they didn't came to a conclusion, they give us some clues about the possible features clinically and on imaging about the aggressive pattern, this aggressive pattern. I won't speak about the clinical aspects, but on imaging, there are two things that we have to look at the beginning, at the onset. The presence of 2 or more GAD-positive lesions, the presence of a high T2 lesion load, high implies in general more than 10 lesions, or the presence of spinal cord or infratentorial lesions are very, very worrisome. And then during the early follow-up, the appearance of 2 or more new GAD lesions or 1 or more new spinal cord lesions or atrophy, especially at the level of the spinal cord, are other things that are predict bad evolution. Then we have combined factors. At the beginning, the presence of 20 or more lesions or T2 or 2 or more GAD positive lesions are associated with a bad evolution. Okay, but fortunately, we can rely on the basic sequences. We can go back to basics. For example, Tintoret in 2018 published this important series in which she considered the presence of T2 lesions on T2, the presence of T2 lesions, the number of T2 lesions, and the presence of GAD-enhancing lesions. And she demonstrated that these lesions are associated with the probability of a patient to reach a new DSS of 6 at 10 years. And you can see here all the combinations, more than 10, more than 20 lesions on T2, and more than 1, 2, 5, 10 GAD-enhancing lesions. when you have more and more lesions, you have more probability to reach this EDSS score earlier. On the other hand, the topography matters. In this paper, Chang et al. Demonstrated that the presence of spinal cord lesions and posterior fossa lesions, but especially spinal cord lesions, is associated with worse prognosis, and these patients reach faster certain levels of EDSS. The course matters here. MS can evolve, can change the pattern, and we have to control the patients every year, at least every year. Now we have the opportunity to switch treatments, to scale. So we have to highlight the importance of these controls. We have to perform the studies with the same equipment, to respect this line. To the repositioning is of paramount importance if we want to compare properly these images. Well, here we have the typical natural evolution of an MS patient. At the beginning, there are isolated discrete lesions without atrophy. Then these lesions tend to confluence. And finally, we have this pattern of end stage with atrophy and a lot of hyperintensities in the white matter. What's the role of gadolinium? Well, gadolinium is very important, as we have seen, and it's important to use it properly. We have to apply a dose of 0.1 millimoles per kilograms. This dose may have to be applied at the beginning of the process of the study, and we have to wait at least 5 minutes before doing the T1 with GAD. During that time, we can use it to perform the T2, the flare, etc. And here we have a patient with a funny pattern of unilateral compromise in MS with a lot of lesions on the left, in the left hemisphere, open rings, some edema, some congestion, some mass effect, but not much on the ventricle. And this is a typical aggressive pattern of a unilateral process. Other features that we have to take into consideration are the black holes on T1. These lesions are usually at the level of the central valley, and they co-locate with the watershed arterial areas. And that has been mentioned that may be a pathoetiological concept of hypoperfusion regarding these lesions. They are not usually seen in the brainstem, in the cerebellum, or in the spinal cord. If we want to, or if we have to rely on the spinal cord and posterior fossa lesions, we have to apply the proper sequences in the studies. For example, in the posterior fossa, we have to do this proton density sequence, which is much more sensitive than the T2 and especially than flare, which is very useful in the supratentorial level. And if we want to see spinal cord lesions, as you know, we have to use STER or proton density, which are more sensitive than T2. In children, there are some aggressive patterns. One of them is the Childers-like pattern, in which we have big lesions, tumefactive lesions with peripheral enhancement, and the evolution of some of these lesions is going to a cystic process, and it's very, very deterioration. It is associated with deterioration of the patient. Here we have another worrisome pattern in children, especially in young children, less than 5 or 6 years old, Here we have a 2-year-old boy with an aiding pattern at the presentation. The evolution showed that this patient went to an MS pattern with discrete lesions and atrophy. And this is why we have to be careful at the beginning when we have an aiding pattern in a boy, in children, because they can evolve to MS pattern. Other clues of aggressiveness, well, we have brain atrophy. As you know, brain atrophy is associated with cognitive decline, which is a feature that presents in 40 or 70% of cases of MS. Here we have that this paper by Di Stefano, who showed that this atrophy, this brain atrophy, can be present in all the forms of MS, including the CIS, the clinically isolated syndromes. Spinal cord atrophy is also important. Some papers show that it is more sensitive to the clinical deterioration of a patient than the brain lesions, but the problem is that we don't have usually the softwares to calculate spinal cord atrophy, and there are some issues about the normatization of this measurement. Regarding cortical lesions, we now know that they are extremely important. We have sequences as FLAIR, 3D FLAIR, or STIR, or DIR, sorry, which are very sensitive to detect these cortical lesions. I would like to mention that there are 3 types of cortical lesions: the leukocortical type, which is the most frequently detected by MRI with a 3T equipment, but there are also intracortical lesions, small intracortical lesions, or subpial lesions, which are very, very frequent, but unfortunately we can't detect them unless we have a 7T unit. We also have to look at the thalami, because the atrophy of the thalami and the presence of lesions at this level is very, very highly associated with bad evolution, cortical lesions, and more EDSS scale of these patients. Another important sequence is the SWI, especially the phase variant of this sequence. In some lesions, we can find these hypointense rings that represent the presence of iron inside macrophages. As you know, macrophages have 2 flavors. In these areas, we can find the pro-inflammatory macrophages filled with iron. And the important is that these lesions tend to evolve, tend to increase their area, their volume, and so they are of very bad, a very bad sign, especially in the progressive forms of the disease. Another lesions that now we are aware of are the atrophied brain T2 lesion volume, because as you know, there are some T2 lesions that tend to shrinkage over time, and this shrinkage is associated with dilation of the ventricles of the subarachnoid spaces. They are associated with atrophy, so the reduction of hyperintensity doesn't mean always a good thing. Regarding the macroglial activation, now we have, we don't have, but there exist some markers, biomarkers that we can use with PET. This molecule PK11195 can bind to macrophages, and so we can detect these chronic active lesions with PET. We also have to look at the 3D FLAIR. sequence after GAD, we can detect these small nodules at the subarachnoid spaces, especially at the convexity, and they are associated with progressive forms of the disease, and they represent a kind of compartmentalization of the immunological response. Now, with these follicles, the patient can produce antibodies inside the CNS. It's interesting to know that MS doesn't have just to do with the presence of lesions. There is the other half of the problem is the plasticity of the brain in order to compensate these lesions. Here we have the model, the nice dynamic model of Stephen Krieger that shows that we have this pool model. We have the water level. We have the floor of the pool, which has a slope, and then the activity, the clinical activity over the water level. You can see that not all the topography is equal. The spinal cord and the optic nerve is more prone to clinical manifestation. Then we have the brainstem and the cerebellum, and finally the cerebral hemispheres. But when the level of water goes down, you can see the appearance of this activity over the level of water, so they can manifest clinically. And what can make that this water level go down? Well, we have the most important concept is aging. With aging, the patients tend to lower the capacity of compensation, but there are also the possibility to have other systemic processes that can complicate this evolution. We have here this paper by Fleischer, who showed the capacity of the brain to compensate, at least at the beginning, the presence of lesions. MS patients use more brain to perform certain tasks in comparison with normal people. Now let's go to anti-MOG very briefly. This is a scary appearance on images, but the evolution is not always bad. Anti-MOG has two flavors. We can have a monophasic disease or a multiphasic process, but as you can see, the sequela between these exacerbations is not that high. Regarding the clinical symptoms, there are two forms. One is the optical spinal phenotype, more common in adults, and the other is the ADEM-like phenotype, which is more common in children. Here we have a typical evolution of a relapsing case of anti-MOG. At the beginning, some lesions in the posterior fossa, the middle cerebellar peduncles, the cerebellar hemispheres, especially at the basal ganglia. After the treatment with the steroids, we have this good evolution with complete resolution of the lesions. Then there was a relapse 1 year later with white matter compromise, cerebral white matter compromise, especially at the parietal level on the right, and an optic neuritis on the right with a lot of inflammation, which after another treatment with the steroids do very well. So here we have a typical case, but there are some issues that we have to take into consideration in these patients. For example, the vision is one of them. Here we have a patient who had optic nerve atrophy bilaterally, but after 1 year, he developed again another exacerbation of this optic neuritis on these atrophied nerves. So this disease can have several episodes of exacerbation at the optic nerves, which can lead to a vision deterioration. Another problem can be epilepsy. Now we know that anti-MOG can have cortical lesions. It can be associated, including with subarachnoid enhancement, and this is manifested clinically with epilepsy. And finally, the compromise of the spinal cord, especially of the caudal part, the conus, can be associated with some sequela as sphincter and sexual dysfunction. Finally, we have the ugly process of this group, which is NMOSD. It's usually aggressive, especially without treatment. It is associated with exacerbation. It is a relapsing process, and the deterioration is related to each episode of exacerbation. As you can see, there is no chronic and progressive phase in this disease, as we can see on in MS, but each episode of exacerbation leaves a sequela. It can have many symptoms, as you can see in this graph, including it can be associated with extra CNS symptoms as myositis or endocrinopathies. And here you can see this cartoon in which there is very nicely represented the compromise of the optic nerves, the chiasm, the optic radiations, the spinal cord, especially at the center of this area, and the brain. We have the possible compromise of the white matter. We don't know yet why these areas are affected, because there is not much aquaporin 4 channels at this level, and the circumventricular area in which there is a lot of aquaporin 4, and there is fenestrated capillaries. Here we have a typical case of an NMOSD. In 2009, the patient developed a left side optic neuritis. You can see the extension all the way back to the chiasm of this process. And 3 years later, this patient developed a huge right side frontoparietal lesion that goes all the way down to the brainstem, following the corticospinal tract. And it is associated with a cloudy pattern of enhancement. Well, the myelitis is very frequent in neuromyelitis optica, and it usually leaves a sequela, clinically sequela. The lesions look ugly. You can see here the expansion of the cord with a heterogeneous pattern of enhancement. Sometimes we have another type of enhancement that is very specific, as is the lens enhancement. Here we have the hyperintensity, which is associated with bright spots, typical of this process. And it usually compromises the cervical cord, going up to the cervicomedullary junction. But in MS, we have two types of lesions. We have the lytic lesions, as we saw before, but we also have another type of lesions, the non-lytic one, which are associated with a better prognosis. For example, the area prostrema or the subependymal lesions are associated with good prognosis. You can have a patient with hiccups or vomiting during a while, maybe 1 month, but after that, the patient do well, and there is sometimes complete resolution of these lesions. They are thought to be associated with fenestrated capillaries, the passage of the antibodies with modulation of the channels of aquaporin 4 and the presence of edema, but there is no recruitment of complement, so there is no lytic or destructive process. But finally, I would like to highlight the importance of the timing of images. Sometimes if we study the patient very early, we can see part of the problem. You can see here a patient with a small lesion at the the cervicomedullary junction, but after 2 days, you have the progression of the lesion to the upper cervical spinal cord, and finally the whole picture with the myelitis. So sometimes it's useful to follow the patient and to repeat the study in order to get the whole picture. Well, and with this, we conclude this video. I hope you enjoyed it, and please subscribe to the channel if you like it. See you next week. Bye-bye.